I'm Carol Eastberg, registered nurse, Nevada State RAI MDS and OASIS Education Coordinator with the State of Nevada, the Division of Public and Behavioral Health, and the Bureau of Healthcare Quality and Compliance. I hope that my slide presentation today is pleasing to your eyes. We are undergoing accreditation, and the folks that are in charge decided that we needed to totally rebrand our department, our bureau, our division. So that's why my slides are going to look different today from Chris's. He's using the template that we used last time. And I would encourage you, if you decide to print them out, print in grayscale, because I hate wasting ink. And there's a lot of ink to be wasted with pictures like this, what you're seeing right now on the first slide. So I apologize. I have no control over that. All right. My colleague, Chris Cristiano from Medicaid, and I thank you for joining us today for part 2 of this training on resident assessments and the much anticipated coming changes on October 1 of this year. Excuse me. Our agenda today does not include a break, so if you need to take one, please do so and hurry back as soon as possible so you don't miss anything. And like I said, handouts were emailed to everyone this morning. For those of you who are just joining us, if you didn't receive them, or if anybody didn't receive them, please check your inboxes and or your spam or junk folders. They may have been diverted there. Also, in the invitation, I provided a link to the most current version of the RAI manual, which is still in draft form. And I requested that you have it handy for reference today, because there is a lot of important information there, but it's too much to put on the slides. And as we go through the different topics and scenarios, I just want you to have it handy to refer to. I will be referencing different pages from where I got the information that I'm presenting. So just to reiterate, today's session is a continuation from where we left off on May 17th. And I'm also going to add answers to some questions that were submitted in the evaluations from that May training. After this portion of today's session, attendees should be familiar with changes to the item sets, understand how to properly code the items, and understand the importance of the IDT in the assessment process and creation of, along with updates to, the comprehensive care plan for each unique individual resident in your facility. Hopefully you were able to attend the recent CMS training that was presented in a 2-part format. There were videos to watch on YouTube, excuse me. And then there was a live presentation where they went over all of the materials. I did attend that. There was a lot of information. And as usual with CMS, you know, information is constantly changing. So that's why I recommend that you check back regularly on the CMS website, where you can find the most current edition of everything. And I know sometimes it's a lot of links to wade through, but they usually do have the most current thing listed at the top. So
Carol?
Hello.
We can hear you now, I think.
You
Yeah,
couldn't
I
hear
can
me
hear you.
before?
Nope.
Why didn't somebody say something?
Yeah, you were muted, Carol. I'm sorry. I'm not
Well,
sure.
I unmuted myself when we started. I don't know who muted me. Okay, I'm going back to page 1, slide 1. Let's try that again without the oops. Anybody familiar with the movie Independence Day? Can you hear me?
We can hear you now.
Yes, we can hear.
I picked the wrong day to stop drinking. Another movie quote. Good morning, everyone, and welcome to today's training, MDS 3. What?
Are we gonna have to deal with this situation already?
Would everybody please mute themselves if they are not presenting? Whoever's calling from the phone number 702-952-2273, please mute yourself. Thank you. Gary, you have your hand up. I'm trying to answer it.
I was just letting you know that we could hear you again.
Oh, thank you.
Thanks, Carol.
Take 3. Good morning, everyone, and welcome to today's training, MDS 3.0 Updates and Long-Term Care Changes, Part 2. I'm Carol Eastberg with the state of Nevada. I'm the RAI Education Coordinator with the Division of Public and Behavioral Health, Bureau of Healthcare Quality and Compliance. My colleague, Chris Cristiano, and I thank you for joining us today for part 2 of this training on resident assessments and the much anticipated coming changes on October 1 of 2023. Apple, I just muted you. Our agenda today does not include an official break, so please take one as needed, but please hurry back so you don't miss anything. Hopefully everybody got their handouts. In the invitation I provided a link to the most current version of the RAI manual and requested that you have it handy for reference today because there's a lot of information for you to reference, but it's too much to include either on the slides or for me to tell you. So I just want you to have that open and available to look at. I'll be referring to different pages of it today, so you can refer to it. As mentioned, today's session is a continuation from where we ended on May 17th. And I'll also be answering some questions that came from the evaluations submitted after that training. All right. After this portion of today's session, attendees should be familiar with changes to the item sets, understand how to properly code the items, and also understand the importance of the IDT or interdisciplinary team in the assessment process and creation of, along with updates to, the comprehensive care plan for each unique individual resident in your facility. Hopefully you were able to attend the recent CMS training on the upcoming changes. It was a two-part training where the first part was you watched some videos on YouTube, and then they had the live training where you answered polls and basically tested yourself on what you remembered from the videos. So the REI manual is still in draft form, and so the information presented today will probably be changing, but not in a substantial way. CMS has promised to get the final version out to us soon.
I can hear that.
Somebody is talking. Please mute if you're not presenting. Thank you. But I can tell you that there's a lot of redundancy in the version that's out right now, so you have to kind of wade through it. And that's why I recommend that you check back regularly with the CMS site. I believe I provided the link for you, and it is on the last slide of this presentation. And that's where you want to go to find the most current item sets, as well as the REI user manual. All right. Section I. We went over this section in May, but several attendees indicated they still had questions about it. And since no specific details were provided, I've put on my mind reading hat and will attempt to address what I hope are the questions. The items in this section are intended to code diseases that have a direct relationship to the resident's current functional, cognitive, and mood or behavior status, medical treatments, nursing monitoring, or present a risk of death. And this is so you can generate an updated, accurate view of the resident's current overall health status. Whoever just joined us, please mute yourself. Thank you. So this section is where you will indicate the resident's primary medical condition that best describes the main reason or primary reason that requires this Medicare Part A stay. And the most important factor in deciding on the primary and active diagnoses is going to be the documentation in the resident's medical record. And that starts with the acute care facility physician's H&P, any surgical reports, test results, medication lists and treatments, any therapies, progress notes, etc., plus the discharge diagnoses and orders. Add this to your SNF admitting physician's H&P, medication list, therapies ordered, and treatments ordered, admission and any consult notes, and you should be able to determine what the primary reason is for the SNF admission. Sometimes you do need to put on your sleuthing hat and ferret out the required information. Insert a picture of the Pink Panther right here with Inspector Clouseau. The information on the slide right here, this number 5, is from page I1 or 344 of the 1694 page PDF. And this is CMS's criteria for determining what can be coded in Section I, active diagnosis, from page I7 in the manual. So they define active diagnoses as physician documented diagnoses in the last 60 days that have a direct relationship to the resident's current functional status, cognitive status, mood or behavior, medical treatments, nursing monitoring, or risk of death during the 7-day look-back period. Just FYI, for the rest of the presentation, anytime I mention physician, think to yourself also non-physician practitioners, which does include advanced practice nurses, physician assistants, and clinical nurse specialists. Please also note that there's a different look-back period for UTIs, and that's 30 days, which we'll talk about in a little bit. So the nurse assessment coordinator needs to review the record for the time frame of each diagnosis to determine if the following criteria are met. A, was the diagnosis documented by a physician or allowed NPP in the last 60 days? B, does the diagnosis have a direct relationship to the resident's limitations in functional or cognitive status, mood and or behavior, medical treatments administered? Do they have a need for nursing monitoring, or does their condition present an increased risk of death? And number C, did any of the above occur during the 7-day look-back period? CMS defines functional status and limitations resulting from a decreased range of motion, contractures, muscle weakness, fatigue, paresis or paralysis, or a decreased ability to perform ADLs. If the resident is assessed to have any of the conditions listed here, excuse me, there should be clear documentation in the medical record. The IDT should be aware of all of them, and they should be coded in the appropriate assessment item set. And by that, I mean nursing comprehensive for the admission, a quarterly, annual item sets. CMS defines nursing monitoring as the need for a licensed nurse to provide specific monitoring and observations to determine if current medication protocols are having the desired effect. And obviously, if there were issues, they would report that to the physician or the primary care provider, and dosages of medication might be adjusted, or whatever needs to be done. But that's why you need skilled nursing to monitor that. All right, the manual says to complete this item only if A0310B equals 1, which would indicate this is a 5-day PPS, Medicare Part A assessment, or if the state requires it with an OBRA assessment. The 13 categories listed here frequently require post-acute care upon discharge from an acute care facility stay. To code this item, keep in mind that the medical condition needs to have been active during the last 7 days. And how do you determine if it was active? Physician documented in the last 60 days must have a direct relationship to the resident's current functional status, cognitive status, mood or behavior, medical treatments, nursing monitoring, or pose a risk of death, and it occurred during the 7-day look-back period. So any of the items in I-20 can be checked, or you're going to enter a code, just one code in that enter code box for the primary. Let's consider a few examples. Resident A, who is 67 and has a 10-year history of Alzheimer's dementia and a 5-year history of insulin-dependent diabetes, was admitted to acute care, 10 days ago with hemiplegia secondary to a non-traumatic subarachnoid hemorrhage. The resident transferred to your facility yesterday. I left a line there for you to enter the code. And if we were live, I would ask, what would the code be? And you all would answer 01 stroke, because the physician's H&P documents stroke as the reason for resident A's admission yesterday. Hello, who just joined us? Hello?
Yeah. Yes, I had to register myself again.
In this second example, resident B was hospitalized for a displaced articular fracture of the left femur head. They underwent a total hip replacement and is now being admitted for rehabilitation. The admitting physician documents that resident B's primary medical condition is a total hip replacement in the medical record. The hip fracture requiring the total hip replacement is also documented in the medical record in the discharge summary from the acute care facility. In this case, it would be coded as a 10, fractures and other multiple trauma, because the H&P documented a fracture of the left femur head, and then there was also documentation of surgery. In example number 3, resident number C underwent a total hip replacement 2 years ago and has a long history of high blood pressure. They were just discharged from an acute care facility after an extended stay for treatment of idiopathic pancreatitis. While there, a central line was placed for the administration of TPN, or total parenteral nutrition. They also received regular glucose monitoring with sliding scale insulin coverage for hyperglycemia. This would be coded a 13, medically complex conditions, because the principal diagnosis of pancreatitis was included in the hospital's DC summary. Examples of medically complex conditions, according to the manual, include diabetes, pneumonia, chronic kidney disease, open wounds, pressure ulcer or injuries, infection, and disorders of fluid, electrolyte, and acid-base balance. These are all conditions that require close monitoring and possible treatment adjustments. Note that the surgical placement of the central line does not change this resident's care to a surgical category, because central line placement is not considered to be a major surgery. The next part of section I is for documenting any other active diagnoses a resident has had during the last 7 days, and you may check all that apply. Note that there is one exception to the 7-day look back under the subheading of infections. Specifically, I-2300 UTI, excuse me, has a 30-day look back period. If the resident's diagnoses are not listed in any of the 13 groups provided, there is another section, I-8000, where you can enter them along with the ICD-10 codes. Page I-11 of the manual has an excellent and specific information regarding what to look for, such as the physician may have actually documented that this condition is active. And if the physician does go ahead and document that, Maybe it's hypertension that's out of control and needs skilled nursing for monitoring of the medication adjustments, which would be the active treatment. Well, there you go. That's your active diagnosis. One of them anyway. All right. Page I-7 of the manual states that there are 2 look-back periods for this section and provides the steps shown here to identify them. Identification of diagnoses, noted as step 1 in the manual, are those diagnoses that were documented by a physician or non-physician provider in the last 60 days. Emphasis on 60 days. Sources where you might find this information include progress notes, the most recent history and physical, transfer documents, discharge summaries, and maybe a diagnosis or problem list, etc. The manual notes that if a diagnosis or problem list is present in the record, only diagnoses confirmed in writing by the physician or non-physician practitioner should be entered in the MDS. So in other words, if you have a list of diagnoses and problems, if it's not confirmed in writing in the medical record by the provider, then you should not enter it in the MDS. The second step is to determine which diagnoses are active. Remember, active diagnoses are those that have a direct relationship to the resident's current functional, cognitive, or mood or behavior status, medical treatments ordered. They require nursing monitoring or carry a risk of death during the 7-day look-back period. You should also review any transfer documents, physician progress notes, recent history and physical, recent discharge summaries, nursing assessments, nursing care plans, medication sheets, doctor orders, consults, and official diagnostic reports, and other appropriate sources as available to determine which diagnoses are active. Do not include conditions that have been resolved that do not affect the resident's current status or do not drive the resident's plan of care, or something for which they are not receiving treatment during the 7-day look-back period. These would be considered inactive. Like I mentioned earlier, the one exception to the active status look-back period applies to urinary tract infections. Whoever's shuffling the papers, please mute yourself. UTIs have a special look-back period of 30 days when determining the active status. In addition, the manual instructs you to code a UTI only if both of the following conditions were met in the last 30 days. You must have a positive determination using evidence-based criteria such as McGear, NHSN, which is National Health Safety Network, I believe, or LOBE in the last 30 days, and documentation of a UTI diagnosis by a physician or non-physician practitioner in the last 30 days. Remember, you will need both, you will need evidence that both criteria are met in order to code a UTI as an active diagnosis. Please see the RAI user manual beginning at page 355, about the third bottom of the page. For complete guidance regarding UTIs, there is a lot. All right. Information sources include, but are not limited to, everything on this list. However, the list is not meant to be exhaustive, but it is a good start for all the documents that would evidence diagnoses and the documentation to be able to code them as active. History can be obtained from the patient or family members, but they're only considered active if they're also documented by the physician within the specified time frame. And as I already mentioned, that also pertains to diagnosis or problem lists. If it's listed on there, it must be confirmed in writing by the physician that it is active within the specified look-back time frame. Something that might be helpful is to have each discipline on the interdisciplinary team review the medical record specifically for anything related to their field. For example, the respiratory therapist could look for any documentation related to tests or results or treatments or issues with the respiratory system. The speech language pathologist would look for all documentation that would indicate there's an active diagnosis related to swallowing or speech disorders, dysphagia, aphasia, and other diagnoses related to that area, and so on. The social worker could look to see regarding, I think, their psychosocial status and that. So that's something to keep in mind. That's how your interdisciplinary team can all work together and help to identify those active diagnoses. Page 355 of the manual has several additional tips, including what to look for that might indicate ongoing active disease processes, as well as symptoms and abnormal signs that might indicate a new or worsening problem. Look at medications and other ongoing interventions or monitoring requirements. We all get interrupted sometimes, and physicians may get interrupted or sidetracked and fail to document that a diagnosis is active. So if you happen to discover this scenario, you could bring it to their attention so they could document it and make sure that the record is accurate and current. Let's talk about some examples of active diagnoses. In this first example, a resident with high blood pressure is prescribed Hcqc. There are physician's orders for regular blood pressure monitoring with parameters to notify the physician of. This would be considered an active diagnosis because of the need for ongoing monitoring to ensure treatment efficiency. There might also be a need to adjust the medication dosage, which of course would need to be monitored again to make sure that the new dosage was having the desired effect. In the next example, a resident with atrial fibrillation or AFib is prescribed warfarin to decrease the risk of embolic stroke. The resident must be monitored for changes in heart rhythm, abnormal bleeding, and coagulation tests. I would ask, and y'all can raise your hands if the answer is yes, is this a scenario or diagnosis that poses a risk of death if the patient was to develop a clot and it went to their brain or their lungs?
Oh, yeah.
Yep, absolutely. So it falls into the category of an active diagnosis, right? Thank you. I see your hands raised. Thank you. You can put them down. It's the only way I know how to interact on this thing since we're not live in person. All right. This example describes a resident who recovered completely from pneumonia 2 months prior to this admission. The resident had no lingering effects or any treatments related to pneumonia during the 7-day look-back period. Pneumonia would not be considered an active diagnosis because the residents completely recovered and there was no treatment during the look-back period for pneumonia. Listening to lung sounds and checking O2 sats would not be considered skilled nursing monitoring because everyone's lungs should be checked, and O2 sats, checking O2 sats is basically just like taking vital signs. It's another step in taking vital signs. So, and you don't need orders for it unless the doctor's looking for certain parameters. Okay, example D. This resident was diagnosed with coronary artery disease and underwent an angioplasty 3 years ago, which is indicated on a problem list. The resident has had no symptoms and no treatment for coronary artery disease was provided during the 7-day look-back period. So I-0400 CAD would be considered inactive. The next example, we have a resident who fell and fractured a hip 2 years ago. After surgical intervention and several weeks of therapy, the resident is now walker dependent and requires assistance with lower body dressing and sit to stand transfers. Although the resident has mobility and self-care limitations in ambulation and ADLs due to the hip fracture, no therapy services were provided during the 7-day look-back period. Therefore, I-3900 hip fracture would be considered inactive. Our last example in this section describes a resident, excuse me, who had no documented evidence of a psychiatric diagnosis upon admission to long-term care. The primary care provider prescribed an antipsychotic medication and documented on the order it was for schizophrenia. The medical record lacked a detailed evaluation of the resident's mental, physical, psychosocial, and functional status and persistent behaviors by an appropriate practitioner, which would be a psychiatrist, for 6 months prior to the start of the antipsychotic medication, and that would be in accordance with professional standards, that detailed evaluation. We aren't given any details as to how the physician who ordered the antipsychotic diagnosed this resident with schizophrenia. So your question should be, why was the antipsychotic prescribed? It may have been because the resident was confused about their new environment and was resisting care from all these unfamiliar people. Or perhaps they kept loudly vocalizing the same thing over and over, like, help me, or want to go home. Or maybe the resident kept trying to, or actually did, elope. In any of these instances that I just listed, use of an antipsychotic medication would be considered a chemical restraint, which is prohibited and could be cited as a deficiency. Even though the physician documented schizophrenia on the antipsychotic medication order, I-6000 schizophrenia should not be coded as active due to the previously noted lack of documentation for the required time frame of 6 months. And right now, I want to just kind of give you a little update that CMS has contractors going out and targeting facilities that have submitted assessments that out of the blue, all of a sudden, this resident who's been in the facility for a while, or maybe just was admitted, all of a sudden they're on antipsychotics, but there's no documented evidence that they've had it for years, or there's the documentation of what's been going on for the past 6 months. So both facilities that have had this targeted audit have failed, unfortunately, because the documentation was not in the medical records that needed to be there. So this is just an alert that you all be aware that if they're on an antipsychotic, excuse me, they need to have at least 6 months worth of documentation of the behaviors. That includes hallucinations, whether they're auditory or oral, excuse me, not oral, via the ear. They might hear or see things that aren't there. They might have a totally warped sense of reality. You know, they might think somebody's out to get them, or they're hearing voices telling them to do something. Those are all evidence of psychiatric issues that would be appropriate to have an antipsychotic ordered. But you must have that documentation in the record in order for that to be considered an active diagnosis and to not fail an audit by the CMS contractors who are specifically looking at orders for schizophrenic drugs, or I should say psychotropics for residents who don't have psych diagnoses. Okay, I'm going to pause right here for just a second because I see a couple of people have had their hands up for a while. Catherine and Jane, if you have legitimate questions, please go ahead and unmute yourself. Or actually, I can unmute you, I think, and let you speak. I'm going to lower both of your hands. I'm going to try to. Okay, thank you, Catherine. All right, moving right along. I got some questions about how major surgery is determined. So the next items we'll go over are in section J, health conditions, where that is addressed. So J2000, prior surgery, asks if the resident had major surgery during the 100 days prior to admission. Please refer to page J43 of the manual, where you'll see a complete list of major surgical procedures. If a resident had one of the surgeries listed there, you can code it as major surgery. But why would you want to know about any recent major surgeries? Because having had major surgery can potentially affect the resident's recovery, especially if they're already debilitated, right? So not only that, but having just had major surgery is probably one of, if not the main reason that they're being admitted to your facility, because they need ongoing post-acute skilled care and rehabilitation to help them recover from the surgery. In fact, item J2100 asks, did the resident have a major surgical procedure during the prior inpatient hospital stay that requires active care during the SNF stay? According to the manual, major surgery refers to a procedure that meets the following criteria. The resident must have been admitted to an acute care hospital for at least 1 day in the 100 days prior to admission to the post-acute, which is the SNF facility, and the surgery carried some degree of risk to the resident's life or the potential for severe disability. This major surgery criteria is the same for both J2000 and J2100. So you need to identify any recent surgeries. And the surgeries that you're going to enter into this section, again, must have been documented by a physician or an NPP in the last 30 days. And the major surgery must have occurred during the inpatient stay that immediately preceded the resident's Part A admission. The list of major surgical procedures that would require active skilled nursing care start on page 402 of the manual. Sorry, I'm sucking on a cough drop because my voice is getting raspy. So I think I just mentioned this. So there you go. Surgeries in this section must have been documented in the last 30 days and must have occurred during the inpatient stay that immediately preceded the resident's Part A admission to the SNF. Page 403 of the manual states, do not include conditions that have been resolved, do not affect the resident's current status, or do not drive the resident's plan of care during the 7-day look-back period, as these would be considered surgeries that do not require active care during this SNF stay. Check the following information sources in the medical record for the last 30 days to identify active surgeries. And again, that would be transfer documents, physician progress notes, recent history and physical, recent discharge summaries, nursing assessments, nursing care plans, medication sheets, doctor orders, consults, and official diagnostic reports, and other sources as available. Check the dates to make sure they're within the last 30 days. The manual does provide guidance in case the medical record lacks specific documentation indicating that a surgery requires active SNF care with the following. It states, the inherent complexity of the services prescribed for a resident is such that they can be performed safely and or effectively only by or under the general supervision of skilled nursing. All that to say that if a resident is admitted to your facility and they have very complex and detailed orders for services that they need that can only be performed by skilled nursing or skilled therapies, then that would be considered an active skilled nursing facility care diagnosis. So for example, skilled surgical wound care or management, which entails dressing changes, observation for signs and symptoms of infection, which would include the amount, the odor, the color, how the drainage looks, what the wound bed looks like. Does it, need something? Does the doctor need to be alerted that whatever's going on with that wound, your average Joe off the street wouldn't be able to take care of it in a skilled nursing way. So you need skilled nursing, and that would be something that would require active skilled nursing facility care. Additional examples include daily skilled therapy that they might need to restore functional loss after they've had a surgical procedure and now they're weak in a weakened state. Administration of medications along with monitoring that would require skilled nursing. So basically, we're talking about all post-surgical care that would be required after a surgery, but they don't need to be in an acute care setting. So they come to the skilled nursing facility for the skilled post-surgical care that they need. Okay. To recap, we covered the definitions for active and inactive diagnoses, functional status and limitations, and what constitutes nursing monitoring. And we went over several examples. We discussed the different look-back periods to determine whether a diagnosis would be considered active or inactive, as well as documentation requirements for the same. And we talked about how UTIs have a different look-back period and two very specific criteria that must be met in order to code a UTI as an active diagnosis. And finally, we went over how to determine if a resident had major surgery and if it required skilled care in a SNF. And now I will unmute everybody. No, cancel that. Please raise your hand if you have a question and I'll unmute you individually. Thanks. Not seeing any hands raised. There's one. Sorry, Bernard, I'm trying to unmute you, but it's not working. Huh. There we go. You're unmuted. Go ahead, Bernard.
So my question is this, is the two criterias the only criteria that is acceptable, or let's say a facility has their own criteria for determining a UTI, which should be utilized? Thank you.
So your question, as I believe I understand it, is can the facility use their own criteria to determine if a UTI was active during the 30-day look-back period? Is that correct?
Absolutely. Thank you.
Okay, thank you. Well, these are the CMS federal guidelines. So I would have to say that your facility needs to adopt the same criteria that CMS prescribes so that you would be in compliance. Does that make sense?
Yes, it does. Thank you so much, Carol. Appreciate
You're
it.
welcome. Thank you. Anybody else? Going once? Going twice?
Sold.
Okay, I am going to turn this over to Chris.
Thank you, Carol.
Welcome, Chris. I just stopped sharing, so hopefully you'll be able to do your thing here. Thanks, Catherine.
Okay, can everybody see my PowerPoint? And can
Yes.
everyone hear me?
Yes and yes on my end.
Okay.
Oh, cool. Look at the thumbs up. Love that.
Lots of thumbs up. That's good.
Okay, I'm going to mute myself.
Okay. So today we're going to be going over the Medicaid review process. My name is Christopher Cristiano, and I am the State Case Mix Coordinator with Nevada Medicaid. And I want to thank you all for taking the time out of your day to participate in this training. I also want to thank Carol for collaborating with me These have been a technology challenge for both of us. And the last 2 reviews we have some more people coming in. I'm going to admit them right now. Okay. So as I said, I am the state case mix coordinator. I hope that you find this information helpful about our Nevada Medicaid review process. And I know that some of you have worked with Nevada's Medicaid's case mix program in the past. And I also know that a lot of you are new and probably haven't had the opportunity to work with us at any time in the past. So I thought that this would be a helpful presentation on what we do and just an overview of how our reviews go typically. Okay. So we will also in this presentation will cover upcoming changes relating to the review process specifically. And as I said, I thought a refresher would be very helpful. Being that we haven't conducted reviews now for almost, I think, 3 years since the implementation of the public health emergency. In this presentation, we will not be addressing specific items. Can somebody who just came on mute, please? Can everybody make sure they're muted? Hearing some feedback.
Holy cow.
Can everybody hear me still?
Mm-hmm.
Yes, if you could please mute. All right, so we will not be covering specific items related to Pdpm. Mainly, in the last review, we discussed some items about GG and other items review. As I said, it's just specifically to the Medicaid review process. And just a little disclaimer about these changes is that the information I'm providing in this presentation is about the current process that we have had in the past, and that we are still in the process of making changes to the review process through stakeholder work groups and other work groups that we are conducting. Some of you may be a part of those work groups, okay? When the changes do occur and are approved relating to the Medicaid review process, providers and MDS nurses will be notified by email or through the Medicaid website on our new policies and procedures. And as stated in our last training, the 2 main goals with the changes that we're making now are to fully transition to the Pdpm payment model and to a remote review process in the future. And finally, I will ask that if you have questions that I am not able to answer at this time during this presentation, allow me 1 week to get back to you through an email, and I'll respond back to you with the correct answer. All right, so our agenda today will include the following: an overview of the Nevada Medicaid Case Mix Program, our current facility MDS facility review process, our transition to the patient-driven payment model, PDPM, and an overview of the Nevada documentation guidelines, which we did stress in the last training as well. And we'll conclude with any questions you may have. And also about the questions, you may post them in the chat if you want. That will be helpful, or we can just do as Carol did and you can raise your hand. Okay. So on to the next slide here. So what is the case mix program in Nevada Medicaid? We use different terminologies for this sometimes, such as case mix reviews, MDS reviews, verification reviews. But the process is basically a verification review of MDS record submissions to Nevada Medicaid. And those submissions determine that the coding and the documentation matches what was submitted by the facilities on the MDS, and that the payment by Nevada Medicaid is accurate. And in case mix, as noted above, refers to the mixture of residents cared for in your facilities. We have case mix coordinators both in the Reno District Medicaid offices as well as the Las Vegas District offices. And we review around 60 facilities in Nevada, including rural facilities that are classified as freestanding nursing facilities. Nevada Medicaid requires all our verification review nurses to including myself, the statewide MDS coordinator, to obtain credentialing as a resident assessment coordinator, which I believe most of you on this call are. And that, of course, is from the American Association of Post-Acute Care Nursing. Nevada case mix verification review nurses conduct, as I said previously, in freestanding nursing facilities only. And the reviews are determined to support the accuracy of that coding. Previously RUG 3, which is now going to be Pdpm in the future. All right. Moving on to number 4. So Medicaid reviews are done annually, and they're based on quarterly dating for a chosen period. When a facility has an accuracy rate of 60% or less on a quarterly review, a follow-up review will be done within 6 to 8 months after the initial review to give the facility an ample time to receive training on deficiencies and improve their scores. So typically we review around 20% of sample size of your population of a facility's records on the day of the review. We do not review more or less than 20%, and the exception to that is that if 20% results in less than 10 residents, the sample size of the review is then 10 residents. So that seems pretty straightforward, I hope, to everyone. So 20%, but if our sample size is less, we review a minimum of 10 residents. We can also review closed records if the residents selected for our review have been discharged, and our reviews are not limited to Medicaid patients as a sole payer source. The reviews typically consist of 4 primary components: the MDS coding verification review, provider training that's conducted during the review and after the review, and then also another component of our review process in the past was to obtain referrals for what we call our community or our facility outreach community integration services program, which is now actually out of our offices here, and it's been transferred over to ADSD, but we will still be making referrals. And basically that program is a program that looks at individuals that are in facilities and determines if they may be appropriate for community placement. So the program helps them integrate back into the community, both through case management and some money is available to help them obtain housing and things like that, furniture, other needs, DME, those types of things, okay? Another aspect, the less, oftentimes we don't do a lot of this, is to note incidences of potentially fraudulent activities, and then we make referrals to an appropriate agency such as Hcqc or whoever our fraud unit at Nevada Medicaid if we suspect that during our reviews, okay? Some units that work in conjunction with us here at the Division of Healthcare and Financing and Policy are the rates unit and our long-term support services units, and they're all under the umbrella of the Division of Healthcare, Financing and Policy. As I believe I mentioned, the reviews consist of a pre-review process, an on-site verification review process, and a post-review process, and we'll discuss that in more detail coming up. So, as I stated, the nurses that review are both from the Las Vegas and Nevada Reno district offices. And training of our facilities and MDS coordinators is one of our main goals with our program. And we believe it or not, we want our facilities to have a successful review process and score well on their reviews. And we highly encourage the MDS coordinators to ask any questions during the review process or after that they have freely. And of course, we are always available anytime. You can submit your questions that you have at any time through our MDS Pdpm mailbox, which the email link will be provided on the last slide of this PowerPoint. So we base our reviews and errors we find on information that we find in our RAI MDS manual. And always we use the most current version updates that are provided by the CMS and also, even more importantly, the Nevada documentation guidelines, which we'll talk about more at the end of this presentation. And the RA manual is our sole source document. We'll talk more about that. But as will be mentioned later, you always need to refer to the Nevada documentation guidelines. We continually monitor for updates from CMS and related to the RA manual, and then we update the documentation guidelines as needed. So our team members on a review typically consist of 2 primary review staff. One which includes a lead review nurse that is responsible for coordinating the entire review. The lead nurse typically conducts the entrance and exit meetings, completes chart reviews, provides on-site training, assists the facilities throughout the review and all follow-up post-review procedures. The support nurse typically is there to assist the lead nurse with all review procedures and any other task. And as many of you know, the review process is complex, and historically, with on-site reviews can take anywhere from 1 to 5 days. So the purpose of our reviews are multifaceted, and as mentioned before, is to ensure the correct MDS coding that reflect an accurate Medicaid reimbursement rate. Other purposes of case mix review identified in our policies are to ensure that facilities MDS coding accurately reflects the resident's medical, social, and psychological status at the time of the assessment. One of the things that is often realized by our facilities, and we've discussed already, is that we provide training to hopefully improve your accuracy, not only, well, mostly during your next review, if you do not score, what you were hoping to. We do provide that training, and that's why we have these trainings. So training error codes is training on error codes is part of our duties as MDS reviewers here at Nevada Medicaid, and as my responsibility as a state case mix coordinator. And as I said earlier, we also identify those individuals who may qualify for our focus programs, and then of course monitor for that fraud, and then refer to appropriate agencies for that. So our review process procedures, we see them here. The notification of the review is the first process. We have the entrance meeting, the pre-chart review, the actual review of the RUG items, and then we conduct an exit meeting, and then there's a post-review process that happens, as well as after that, some follow-up training typically. So the lead nurse will reach out to the MDS nurse at the facility, and we do keep a hopefully up-to-date email of all the MDS nurses at each facility. I encourage you, if you are new to a facility and you're not receiving emails through the MDS Pdpm mailbox, to click that link at the end of the training and email me and let me know you'd like to be added to that list. That way you get all the current updates and any changes that we're making. So the lead nurse will initiate the entrance meeting and provides the MDS coordinator with the information on records requested to be reviewed. We have that entrance meeting, and we usually have several participants from your team there, which include usually the administrator, the MDS nurses, of course, social services staff, and any other staff that the administrator or the MDS coordinator or the MDS team agree on that need to be present at that meeting. Okay. We do introductions, we explain the review process, and then typically we close that meeting. We ask answer any questions that you may have. And then we work solely, typically, with the MDS nurse on getting the records that we're going to review. Something that should be mentioned is that during these reviews, both historically and as we go to hopefully a remote review process, is that the records that we request, of course, need to be supplied in a timely fashion. We are limited on our time that we can be at the facilities typically. And when we request a record, if it's not available, sometimes that can be an issue. Okay. After the review is completed, we typically calculate all the scores and we go over that with the team. It's usually the same persons that were in the initial entrance meeting. And we discuss our findings and we discuss the errors as well as any suggested training. And at that time, we may schedule the training, or not at that time, but actually we follow up with the training process later, okay? Before we start initiating reviews again, it is my goal to get some type of PowerPoint together or a more in detailed pamphlet that we can send out to facilities that outlines the process that you're seeing on this slide here, so that all the MDS coordinators in the facilities are clear on how the review should go, especially as we initiate a remote review process. Okay, so what are we looking for? We've mentioned this already, verifying the accuracy of the MDS items coded. We also do a pass-out review during our reviews. We also check on other things such as patients' rights being posted in the facility. And we look for medical record documentation that supports that coding, okay? And per the RAI manual, which you see on the slide here, the intent to process definitions, coding instructions, and clarifications, and any of Nevada Medicaid supportive documentation guidelines that are required for that specific item that we're reviewing, okay? You should have that all in your documentation, and we're going to go over more about some documentation and errors later in the presentation, okay? Something that we highly recommend and we've talked about in our past reviews is that facilities should implement some internal processes that help them score better on their reviews. So especially once we start doing these reviews again and we see how they go, the process, get together as MDS coordinators with your administrators, your nursing staff, and you should have processes in place already, of course, that ensure that the documentation that we're looking for is accurate and supports the MDS coding. And we can kind of help with that as well. Obviously, as I said earlier, we assist with training. So we'll do trainings for your facility, come in at a time outside of the review and schedule a training with all the staff that need to be there, social services staff, nursing staff, etc. So accuracy is basically the same thing. The importance of the accuracy of the reviews are as follows: to reflect the accurate resident status as of the ARD. And something to note about the ARD with Section GG, as we discussed in our last training, we're used to that 7-day look back period with Section G. And then, of course, in the MDS, there are other items that do have a different look back period. So I encourage you all to be familiar with that. Refer to your RAA manual and make sure that you are very aware of what the look back period is. An error can be just a minute, but a few minutes out of the ARD, or if you don't understand the timing on the days of the ARD, that can result in an error and a reduced score for your facility. Okay. Some other important things are it's essential in developing an appropriate care plan. And then, of course, nobody wants to be accused of fraud or Medicaid abuse. Right. So accuracy resources, we mentioned the RA manual. That is our document we use in our reviews for coding. We refer to that, but then the document that ultimately we refer to with certain items, not all items, is the Nevada documentation guidelines. Okay, so the MDS is not a sole source document. Okay. And if you did not know, you can find the most recent version of the MDS manual on the CMS website, which I have there. If you just copy that link, it'll go there. And unfortunately, it's kind of a hodgepodge of information at the bottom of the page. It's kind of hard to find that, but the new version, according to my understanding, and if anybody has different information, please let me know, will be available October 1st, 2023. Okay, so one of the big things with Medicaid reviews is reimbursement for facilities. And I believe that's important to you all as facilities, as MDS coordinators. If your facility is not getting reimbursed accurately, that's a huge thing. So a little bit about our reimbursement. Base rates are paid on case mix index data reported by facilities, okay? And then, if you're not aware, we have in Nevada what we call a supplemental payment program, which is based off your MDS review and how well you score. And that is an additional reimbursement on top of the base rates that's paid. So it is important, very important for facilities to score well on these reviews. Okay.
Excuse
And I'm
me,
just going to,
Chris.
yes, go ahead.
Excuse me. Several people are reporting that the slides have not advanced.
You're kidding me.
I'm looking at the reimbursement slide number 12 right now.
Okay, well, we are on slide number 12. So if you have those downloaded, you can just follow me along that way. I don't know what the issue may be, and I don't want to try to fix it in the middle of the presentation right now.
Yeah.
How many people are saying that they're not advancing, Carol?
1, 2. Only 2, and several are saying that it looks okay now.
Okay, I'll announce what slide I'm on as I go along from here on out, okay?
Maybe there was just a lag for a second in the app.
So we are now on slide 12, and I'll give everybody a minute to catch up if they have not been able to follow along. Okay, so we're going over reimbursement right now, and everybody can hear me, correct?
I can hear you.
Great. Okay, so I'm just going to read you a little excerpt from our policy here, and this is about the supplemental payments. So freestanding nursing facilities supplemental payment effective October 1st, 2011. Freestanding nursing facilities will receive a supplemental Medicaid payment in addition to its standard or special fee-for-service per diem payment. Supplemental payments are not available for nursing facilities owned by the state of Nevada or any of its political subdivisions. Bed days are for all payers and are used in calculating the supplemental payment. And this is how it's calculated. 50% of the supplemental payment is based on Medicaid occupancy. MDS accuracy, so this is where MDS comes into play for us because this is calculated into that, and quality measures. And then the other 50% of the payment is based on acuity. And then the amount for supplemental payments is computed quarterly and reimbursed in the quarter in 3 equal monthly payments. So we're talking about money here. And so accuracy is super important, and understanding that this relates to what you get paid by Nevada Medicaid. Okay, I'm moving on to slide 13, and this is reimbursement continued. So basically this just says that all MDS RUG scores are transmitted into the state database and are averaged each quarter in facility specific rates and adjusted accordingly. Okay. And we work with an agency called Myers and Stafford, which I'm sure some of you are familiar with. And they identify quarterly individuals and current payment sources from facilities. And then they provide that information to us. And that's how we get our sample size typically from our reviews, okay? All right, so data collection and coding decisions, slide 14. We encourage the facilities, of course, to use all permitted resources for coding and decisions, which basically comes down to the RA manual and the Nevada documentation guidelines. The question mentioned earlier about the UTIs. So there is specific information in the Nevada documentation guidelines concerning UTIs, I believe, if my memory recalls correct. So to answer your question from a Medicaid perspective, you would definitely want to refer to that and not your facility's procedures for that. And as Carol said, adopt those procedures for your facility. Okay. Always remember, again, I keep stressing about the look back period. Always refer to that specific look back period for the section that you're coding. Okay, whether it be section GG, a 3-day look back period, or other items on the MDS may have different look back periods. And remember that anything that happened before or after the look back period, we do not review. We're strictly about that look back period. And if the documentation does not reflect that, you will receive an error. So some types of errors. We have typically a no documentation, and that means that there was no documentation found to support the rug item that was coded, either through the notes that we look through or on the MDS itself, or any of the other information that you provide us. If we can't find the information and come to a conclusion as a team that the documentation is not there to support that code, you will receive an error for that out of the ARD. So maybe the documentation may existed, but it's not within that specified ARD range, okay? Conflicting documentation is another thing we often come across, okay? So there's conflicts about what was reported on the MDS. It doesn't accurately report that. We may record it as either a no documentation or a conflicting documentation. Wrong code, I think that's pretty straightforward. And that's basically, it's a different code that was transmitted to the state repository or the MDS coordinator, okay? Pretty straightforward with those errors. And those are typically, those are the 4 errors that we document. And when we go over the exit meeting, we will discuss how many errors you had of each type. Okay, and we tally that up, and that's how and then we add it into the records, and then we come up with a score for you. Okay, so just some examples here, and it should be noted that the Medicaid reviewer will appropriately document all errors, and we document that to defend our decisions and statements in our findings, okay? So oftentimes during these reviews, we will communicate with the MDS nurse. We will give you that opportunity, an ample amount of time to discover that documentation, and we do realize that that's hard to find sometimes because we're looking at records of patients who may have been discharged. Sometimes they have very large records, and sometimes it comes down to going to the paper chart rather than the electronic health record to find that information. So it does take time, and it is a time-consuming process for those of you who have not participated in these types of reviews before. Hopefully, the remote review will make this all easier for both sides, okay? So let's go over these errors here, and these are old examples, okay, but conflicting documentation. So there were 2 or more statements documented within the ARD range that conflicted. The example is C0700, short-term memory was coded 05, and social services notes indicated able to speak and clearly and recognizable. Okay, so note here that the available codes are C0700, R0, and 1. So wrong code, obviously. That would be an error. Or conflicting documentation, I'm sorry. So wrong code here, we have the example of the code on the MDS is different from that transmitted to the repository or the MDS coordinator and states that they coded the item incorrectly. It says that this may have a significant impact on the facility's reimbursement. And this is one of those errors that could be considered fraudulent. Okay, so you probably don't want too many of those. All right. And those are the examples that we have here. Oh, one thing I would like to mention, back to slide 16. As I said, we will provide ample time, but once the review is over, we do not give that opportunity to come up with documentation, just in case you did not know that. Okay, all has to be presented during the review process. So this is really important because it's been 3 years since I've done a review, and I do remember this was often one of the things that came along many times and resulted in errors for facilities. So we see things here, must be signed by the appropriate staff. If we don't have a signature, or maybe somebody else signed, or just didn't sign at all, anything like that, that's going to be an error for sure. Must be dated month, day, and year. Okay, and then with the ARDs, we're also looking at time. So if it's literally a minute after the ARD or before, that's not going to qualify, and that's going to result in an error. Okay, must have the resident's name on. The initial review process, we look at the MDS that was coded, we verify the signature dates, all that. We make sure that the name matches up with what's reported. Social Security numbers, Medicaid numbers, all that. We look at all that, okay? So that's got to be accurate. It must be legible. And I think we know who sometimes are responsible for sloppy handwriting, and that has been an issue in many of our reviews, that we cannot read it if it's not legible, completely unlegible. And sometimes we'll have more than 2 MDS nurses on a review, and we'll have everybody look at it, right? And I can't read this. Can you read this? Can you read this? And then we'll even go as far as asking the MDS coordinator at the facility, can you tell us what this says, if it makes sense? But that will result in an error as well, okay? And again, to stress, the ARD period is super important. So make sure that you have a good understanding of what the ARD is, and those dates that apply to each item that you are coding. Okay. So I put this slide up here because a lot of people, and the feeling I got when I first started doing reviews, is that, we were the big bad state coming in to review. We're trying to debunk that myth that we're there to, get you in trouble or anything. And of course it does revolve around money. So it's important to do these reviews right. But we are not there. We're more there to educate and to hopefully help you succeed on your reviews in the future and get a high score and a higher payment. Okay, so some differences between Carol's job and our job here are outlined. Okay, in Hcqc, they are known as surveyors or inspectors. We typically like to be referred as case mix reviewers, Medicaid reviewers. Okay. Their job at Hcqc is to ensure, and I'm sorry, we are on slide 18. I forgot that detail for anybody who is unable to follow along. So Hcqc ensures federal and state regulatory requirements are met. Our district offices ensure that Medicaid payment is accurate. Okay. Hcqc, they look at the most current MDS assessment date and compare it to previous MDS assessments to make sure that there's no wishy-washy stuff there, fraud, anything like that, forward. And care planning and care plans, and that they're implemented, as well as timing. We don't necessarily look at that type of stuff, okay? We look from the ARD back in time, okay? And we're looking for documentation that supports coding, okay? And on our review, if documentation is different than the code on the MDS, it tells the facility that they have an error and, of course, how to correct it. Hcqc looks at the quality of care and quality of life issues, and if problems are identified, cites the facility with a deficiency. We can't cite the facility with a deficiency. It just affects your payment, okay? Which is a big deal. Some other things Carol asked me to mention as we were going over our presentations yesterday, that Hcqc conducts interviews with residents and or the family as well as staff to determine if record reflects accurate information. And we do not do that. We will go, we don't interview residents, we don't interview family, we're just strictly getting records from the MDS nurses, okay? Their reviews are typically, our reviews are 9 to 15 months apart, whereas we do a review annually, as I mentioned. And they also conduct facility complaint investigations. We refer for complaint investigations, but we do not conduct those. Okay, so those are some of the differences. So slide number 19, our current case mix program. So as you all know, we previously used the RUG-3 items, okay, for our reviews. We will be transitioning fully to Pdpm on July 1st of 2024. A lot of the Pdpm data is already being partially transmitted in to our Myers and Stafford associates, and some of that data will start being available October 1st of this year. And we may possibly start doing reviews on that data as well, depending upon how our stakeholder meetings go, as well as if we determine if we fully want to implement a remote review process, and if we can do it during that timeline, okay? All right, slide number 20, current case mix program continued. A little bit about Pdpm and how it differs from the RUG-3 model is that RUG-3 focused on volume of services. There's been a lot of talk in our stakeholder meetings about therapies and stuff like that. And in the past, we've noticed in our RUG-3 reviews that therapies seem to be, what's the correct word? They seem to be inappropriate at times for the reimbursement we were providing. So what we're being told is that Pdpm corrects that, okay? Pdpm is driven by the resident's condition and resulting care needs and improvement, okay? And it's designed to provide incentives to treat the whole needs of the residents, not just their conditions. Slide number 21, current case mix program continued. As I've mentioned, it was historically an on-site review. If for some reason we are directed to start reviews in October and we do not have the ability to do remote reviews, there may be a chance that we continue to conduct on-site reviews. But our plan is, of course, to go to the remote review process, okay? As these ongoing changes occur, as I said previously, we will notify facilities both through the Pdpm mailbox, as well as on our Nevada Medicaid websites that are associated with long-term nursing services. And I have those links, I believe, posted in this presentation as well as at the end here. Okay. So as I just said, October 1st is a possible start date for us. What else here? The review process notification. Typically, we notified the MDS nurse 1 week prior to our review that we were going to be conducting the review. We're currently discussing whether that is the best option for Nevada Medicaid and our providers, our facilities, and that may change. But as it stands right now, that still is the case. All right, they will still always be annually. And we are currently discussing point in time versus a time-weighted CMI average system. And we haven't fully concluded that yet, but we are leaning towards the CMI average weight system, okay? That's about it for that slide here. Let's see. just a little comparison of RUG3 model versus PDPM, and you did see this in the last presentation that we did. PDPM is a case mix group reimbursement method that focuses on clinically relevant factors rather than volume-based services, and that was the problem with RUG3 we saw with a lot of our codes we were reviewing, because it seemed like providers were maybe bumping up those services. Okay. It's going to improve accuracy, of course, hopefully, and hopefully we've done some initial modeling with Myers and Stafford, and it's actually increased the payment for quite a few providers in Nevada, from what we're finding. Okay. Let's see, go here to the next one, slide number 24. PDPM uses a reverse scoring methodology, and Section G was one of the big sections reviewed in RUG3, and that meant an increasing score meant increasing dependence. With Section GG and PDPM, increasing score means increasing independence. Okay, so there's a non-linear relationship to payment. And the thing about our system is we were quite antiquated in Nevada using a RUG3 when most other states had already transitioned to a RUG4 long ago. Okay, so we are trying to stay up with the times and going over to PDPM now. Okay. All right, very important here, Nevada Supportive Documentation Guidelines. I've talked about this in our last training. This goes over what this is, and we will provide a revised version, hopefully by October, of the Nevada Supportive Documentation Guidelines that include Section GG and any other updates that'll be made to that document, okay? So all of those sections that we'll be reviewing in GG will be added to that by that time, okay? I encourage you to highly familiarize yourself with this item. Even the other items that are listed on there, as we mentioned earlier about the UTIs, that gentleman, please take a look at that. If you're not familiar with this document, that is something that we will use, okay? And it will result in errors if you do not refer to this as the final source. So the procedure would be to look at the RAI manual, see what that says, and then refer to your Nevada documentation guidelines. All right. So this just goes over slide 26 here, a little more information about that. I will give you the ability to read that, if you would please. Look over that and then go to our website, download the most recent version of that. And as I said, start to familiarize yourself with that document. Okay. Signature date is a big thing that on Z0400, and that's something that's mentioned in one of the footnotes of the Nevada Support Documentation Guidelines. I'm not going to read through this for you guys, but I encourage you to read that as well. Okay. All right, so this is just what it looks like here. And one item that frequently comes up in reviews and facilities, and they receive education on, as well as errors, is the as evidenced by statement. You can see that over to the right side of this document. And a lot of the items that are listed in the Nevada Supportive Documentation Guidelines requires an as evidenced by statement, okay? Now you can take the approach of an as evidence statement as, you know, just a great documentation note that clearly defines that specific item and what you're coding for. But what I recommend, and what we talked about in past reviews, is to actually put that AEB. You know, they taught you that in nursing school, as evidenced by. That's helpful sometimes. Although if the note doesn't support that, you can put that all day. But if it doesn't support that, then you will receive an error. Okay. So please look over that very carefully and understand that, because that is something that will probably not change much with our new revised version. There will be lots of as evidenced by statements, okay? All right, and that concludes our presentation here. As I said, I will be getting together a handout or another PowerPoint slide that will be sent out to all the MDS coordinators that goes over the MDS actual verification process, the pre-reviews, the review itself, and the post-review a little more in detail. That's easy to understand. We didn't have the time to review all that today. There is a lot of information about it that was not included in this presentation, little details. Okay, so of course, Carol's information is up there, mine, as well as the MDS Pdpm mailbox. And that concludes our presentation. Thank you. Does anybody have any questions? Go ahead and raise your hand, or you can post it in the chat, I think. Thank you, Paula. All right, good. No questions. That's great. Carol, do you have anything to add, or?
Let's see. I thought of something earlier, but of course now it's gone. I was doing stuff in the background, getting ready to send out the post-test and eval. So,
Do we want to mention, I mean, our goal with these trainings now is, I think, about every 3 months. Are we going to have another training? Is that the plan here
I
soon?
thought it was every other month.
Oh, wow.
Yeah, we got to step it up.
Carol is cracking the whip. Okay, I see a question here. Hello,
Go ahead.
will the recording be available after this live video?
Eventually.
Yes, it will. When Carol figures it out.
No,
Okay.
my public information officer is working on the first one right now, or is supposed to be. And once he figures out how to edit it, so you don't have to, wade through all the nonsense before you get to the meat of the thing, I'll be sending out the link for the first one, and then hopefully he'll get this one done quickly, and I'll be able to send that one out to you in very short time frame.
Okay.
So yes,
Carol, we have another question here.
Okay.
The question is, will Nevada require the OSA? No. We've already determined in stakeholder meetings that we've had that is not going to be a requirement. It's been determined that's a burdensome requirement by providers, and that will not be required by us.
Yay. Oh, sorry. I guess I should do this. Reaction.
Okay, thank you, everybody.